I'm presenting on lessons learned in the control of pandemics generally, but specifically on lessons from the South African response to the COVID-19 pandemic. And I'm one of a number of people who've just published an article in the British Medical Journal, Global Health, on what I'm going to be presenting. And the last slide has a reference to that article. So if folk wish to see what's in that article, they're welcome to look at the BMJ. So I'll be speaking to a number of issues, looking at where we are now in terms of response. Oh, here it is. If you can make this into a slideshow presentation, please. Great. So I'm speaking on behalf of a range of my colleagues who contributed to this slideshow. Ndiwe Madikizela, Mweketsi Madisinyani, Elizabeth Leonard, and Dr. Patrick Munasa. So the presentation will cover these areas, the lessons we learned in a number of areas: community screening and testing, contact tracing, the epidemiology, the risk communication and community engagement, the risk adjustment strategy and how we used it, and the health system strategy and the recovery and reset. So as of a couple of days ago, this is where we are in the epidemic. And as you can see, the first peak, no, the next slide, please. The first peak was around July, and the second peak was around December, early January. And you can see that the second peak was significantly higher, and you can see that peak was much narrower from the beginning to the end of the peak. We are now back to about where we were in October, September, October last year. So the key issue now is, what lessons have we learned from these two peaks, and what do we need to do to prepare for what most of us anticipate, which is a third peak and possibly additional peaks post that. The next slide, please. So the next slide basically shows that we initially relied on, of course, the non-pharmaceutical interventions, and we are now focusing on the vaccines as a significant approach to mitigating transmission. And this slide basically shows the various phases that I think are now well known, that have been released by the Minister of Health. And the first phase, of course, being limited to 80,000 doses in the first instance, followed by probably another 80,000 doses, focusing on the 1.25 million healthcare workers. And phase 2 will expand the number of essential workers that are covered, together with people in congregate settings, including prisons, and people over 60 and those over 18 years of age with comorbidities. And the comorbidities are largely around diabetes, hypertension, and cardiovascular disease. And then the third phase would be to cover as many of the population to get population level of immunity. So we're looking at approximately 40 million people being vaccinated across phases 1 to 3. But let me emphasize that notwithstanding the vaccination program, one has to continue with non-pharmaceutical interventions, and that is the consistent use of masks, preferably doubling up on the masks, so 2 masks at a time, hand washing, as well as social distancing or physical distancing. Next slide, please. So this shows the way in which the National Department has been organized to intervene in a fairly large number of areas. And it ranges from governance and leadership through to ensuring that all the medical supplies are in place to ensure that patients who need treatment get it. There was a significant amount of activities, as you can imagine, around ports of entry, as well as environmental health. We did a fair amount of modeling to model the pandemic and to model response, including laboratory-based surveillance. And there was a lot of work done in preparing our health facilities, as well as ensuring that there was proper clinical case management. And as I said, there was a fair amount of work done on communication and community engagement. And we can talk about where the gaps are there, because you can never do enough of that. focusing on occupational health, both for health workers as well as all other workers as people return to work. Significant focus was on infection prevention and control. It is an airborne disease, pretty much like TB is. And then, of course, protecting the health workforce. We focused a lot on the health workforce, because without the health workforce, really, you can't do much. Next slide, please. So with that as a background, what were the key lessons learned from both first and second waves? Next slide, please. So we'll focus on the following areas. I mean, we can't be fairly significantly more exhaustive. Just before the first wave and during the first wave, community health workers were mobilized to do community screening and referral. And we attempted at that time, because the numbers were small, to do contact tracing once an index patient was known. There was active and informed use of epidata. And as I said, community engagement and risk communication was a feature of the response from the first phase. Using the risk adjustment strategy, we tried to look at when lockdowns were put in place, the different levels of lockdown, what the impact was, certainly on the health system and on cases and mortality. And then we spent some time, of course, preparing before the first wave and during the first wave on strengthening the health system. The next slide, please. So on the community screening, a significant amount, around 55,000 community health workers and outreach team leaders were mobilized to go into communities and do screening. So they weren't doing swabbing, because that's not allowed, but they were screening, doing symptom screening, and referring those for those that screened positive for testing. And one of the big challenges that we had during that period was that the laboratories weren't able to cope with the number of suspects, that people with symptoms that were referred for testing, because the testing was at that point PCR-based testing and not antigen testing. So we didn't have a rapid test, the 15-minute turnaround test, which we now have, the antigen test, during March, April, and May of last year. Another big challenge, of course, was that symptom screening does not, and is not able to screen in or screen out those without symptoms for obvious reasons. So we were obviously missing those that were asymptomatic as well. And curiously, this is the same challenge we have with malaria as well as TB, that there are some of these communicable diseases that present asymptomatically, which means that unless you have a laboratory-based test, you will not be able to test for symptoms. Next slide, please. So we developed a national epidemic community response strategy with clear roles. This phase, at least moving into the first peak, we did strengthen intersectoral and intergovernmental engagements. And I think on that issue, we have to commend the local government as well as the districts who played a significant role in both mobilizing communities and working across government sectors. It was fairly clear from the first wave that the health department working alone was not going to be able to mitigate transmission or to prevent avoidable mortality. So it was a major lesson that unless you work intersectorally and across all three spheres of government, a health sector response alone was not going to be sufficient. Secondly, that communities had to be mobilized at the lowest level. And you saw that with respect to adherence. Adherence to the non-pharmaceutical interventions was significantly higher in communities where there was significant community mobilization and where there was significant involvement by local government councillors. At that time, community health workers who were doing a range of activities, TB, HIV, and the non-communicable diseases, were moved out of those activities to focus almost purely on the COVID response. And one of the negative consequences of that was that the other services, other routine services suffered. And there's data to show that during the first wave and into the second wave, there was about a 40% reduction in the number of people who tested for TB using the Gene Expert test at the laboratories. Um, so, there are many lessons that we've learned from having a singular focus on COVID, which was necessary, but it had some significant adverse events and effects with respect to the rest of the health system. We have been able to use digital health, mHealth applications to support data collection and reporting by community health workers on community interventions. So I think that was a major plus and a lesson learned about the rapid use and mobilization and implementation of digital technology. Next slide, please. So moving on to contact tracing, one of the key things about communicable diseases is early screening, diagnosis, and isolation and quarantine in the instance of people under investigation whose test results are not yet known. So a lot of effort went into engaging communities, using technology, including call centers and bulk messaging systems, and a number of tracing management systems like GoData, Siangoba, and Impilo, to strengthen the workforce that we had at district and sub-district level to track and trace, essentially. And when the numbers are small, this is possible with the warm bodies that we had and the electronic systems. But as the numbers grew, and as you could see from the second slide that I showed, the numbers grew rather rapidly in the first wave as well as in the second wave, that it's quite difficult to do contact tracing at the scale at which it was required. Next slide, please. So the lessons learned, included digital technology and the use of digital technology. One of the concerns, of course, in the use of digital technology, and we saw that in the context of very low uptake of COVID Connect, were people's concerns, the community's concerns about privacy and issues around ethics and security. There were also technical difficulties with some of these management tools. One of the key issues, of course, in getting people out to do contact tracing was to provide them, because they're going to be walking distances or traveling distances within communities, providing them with the bare necessities like food and water. We clearly also had a challenge with stigma and discrimination. And many people did not want to be identified as COVID positive for obvious reasons. We have that with HIV, we have that with TB as well. So it's not peculiar to COVID. And of course, there's continues to be a mistrust of government at the local level in terms of government action, the teams, and technology. And for some people, they did not perceive the benefits of knowing that they were exposed to a COVID positive individual because many of them didn't want to either quarantine or isolate. Even where isolation and quarantine facilities were provided, there was very poor uptake. Many people from poor communities, for example, didn't feel safe to leave their homes because they thought their homes would be occupied by others if they left their homes. Others didn't have adults to take care of young children. So there were a lack of perceived benefits in the contact tracing process, especially with respect to people under investigation and people who needed quarantine and isolation. Next slide, please. So what are some of the key messages from contact tracing is that we've got to, even as we've gone into a trough of low numbers of cases, because the current number of cases that are reported daily are less than 2,000 countrywide, with a few deaths, less than 50 deaths a day reported now. But we still think that it's very important for people to test, either because they have symptoms or they have been in contact with somebody who tested positive. So we need to have a very high index of suspicion around testing. We know that contact tracing only works if it's part of a comprehensive system, that it requires massive investments. And in terms of the current budget allocations for 2021-22, it's fairly clear that many problems provinces are going to struggle to invest in many aspects, including contact tracing. It's a time-intensive and labor-intensive process. We know we can deploy mHealth and digital technologies, but they need to be supported by the traditional contact tracing methods, especially because people are still suspicious of electronic means of communication and surveillance. We know we need to protect the vulnerable, especially the elderly, essential workers, and those with comorbidities. So we need to spend significant more time with shielding those with comorbidities, for example. The health system, we need to really focus on strengthening not just the health system, but also the social system within which the health system is embedded. And we need to go back to an integrated approach to integrating all services, including HIV, TB, and the non-communicable diseases. And we think that we need more people who can analyze data in real time at the local level, so there can be local level action and interventions in real time. And we need to really strengthen our ability to put out these very small fires, because if you don't curb these transmissions when they're happening at a low level, you'll soon find that they become big fires with massive transmission. And finally, we need to strengthen our cross-border contact tracing ability, as well as figure out how to better manage cross-border travel, including having an early warning and response system. Next slide, please. In terms of the use of epidemiological data, I think this presentation really coheres quite well with the previous presentation, as well as the one that Wayne Ramakrishna did. And we've used it, we used the epidata to model, to identify hotspots, to focus on prevention and control strategies in these hotspots, to do tracking and tracing. But there have been challenges with the data. I think it's well known that in some areas we've got very good surveillance data, and other areas not. We have to extend the digital platform. We've got to strengthen the surveillance system. There is some duplication and lack of standardization across provinces, and there's inadequate coordination in many areas. But I think the COVID response has shown that the public and the private sectors have to work more closely together, as should the national, provincial, district levels, and that the only way to get ahead of an epidemic or a pandemic, which grows very fast, is to have electronic data systems. And I think that what's currently being built, both in terms of a lab-based system as well as the surveillance systems, including the modeling system through the COVID-19 Modeling Consortium, will stand us in good stead in ensuring that if and when we get the next pandemic, we will be better prepared from an epi and a surveillance point of view. And I think the surveillance through surge is yet another instrument that can be used in the surveillance system. Next slide, please. In terms of risk communication and community engagement, all the mechanisms for communication have been used, everything from social media through to radio and TV. The president has been excellent in both his family meetings as well as his weekly newsletters, and clearly all the other ministers, including the Minister of Health, have been at the forefront of communicating. But of course, what we found is that communication at the local level, developing a community communication strategy, was key to getting local action. So for example, we worked with community radio stations and community DJs to get the messages across at community level. Some best practices is that I think WhatsApp, radio, TV, the internet, and communicating in all South African languages was a plus. And that I think the communication through the political leadership, the technical leadership, and at the community level did help to build a significant amount of public trust in what government was doing, at least through to the first peak. Certainly there was a significant amount of fatigue going into the second peak, and we need to better understand how to communicate to people who are significantly fatigued. Some of the challenges, spread of misinformation and rumors For example, that Bill Gates put a chip into the vaccine, and if you get vaccinated, you will be under surveillance by Bill Gates. That's just one of them. There's resources are always finite, so there's a challenge with resources. And I think it's true to say that we could have had a significantly more support and communication from other government departments. And I think going forward, that could increase. Next slide, please. In terms of the risk-adjusted strategy, I think it's well known now that we have a 5-level alert system, and that we are now in adjusted level 3. And I think it evolved out of significant consultation across all sectors, including the private sector, notwithstanding the fact that it did cause a significant amount of social and economic pain because of the lockdowns. So I think going forward, we need to learn lessons from what works and what doesn't work at each of the levels, and what can be done differently. There's been suggestions that you need a significant amount more of community buy-in before you institute an alert level of one kind or another, which clearly means that we need to have some kind of balance between not only what's done and how it's done, but also between saving lives and saving livelihoods. And I think that's now become fairly clear. But that's a difficult balance, I think we all admit, to achieve. Next slide, please. So in terms of health system strengthening, a significant amount of effort has gone into this, and that is specifically around ensuring that community health workers and clinic and hospital staff have the right protective equipment, personal protective equipment, that they are in stock, they are of good quality. And of course, the allegations of corruption around them and the price gouging around them are a significant stain on the procurement of PPEs. We spend a lot of time in strengthening the stock visibility system to manage not only PPEs, but also stock levels of all the other commodities required. There was an increase in the number of field hospitals built and beds, both general beds, high care beds, and ICU beds that were repurposed to take care of COVID-positive patients. And healthcare workers were also repurposed in terms of moving them around into the so-called COVID wards and retraining and training healthcare workers to take care of COVID-positive patients. So there were, of course, challenges: not enough staff, in some instances, not enough oxygen. So we spent a lot of time also ensuring that oxygen tanks were available, both the permanently placed oxygen tanks as well as the portable oxygen tanks. There was significant use of engagement with the private sector to develop thousands of ventilators, to build thousands of ventilators to ventilate patients. And of course, we learned a lot from a clinical perspective on what works and what doesn't work, both from the clinical aspect, from what drugs to use and in what combination, as well as the issue of high flow and nasal air, as opposed to ventilation in some instances. So I think the lesson from the health system strengthening is the need, and the lessons from the vaccines is that South Africa has to become more self-sufficient in the production of commodities, whether they are ventilators of various kinds, whether it's production of oxygen, whether it is PPEs, whether it is the selection of drugs, steroids included, or whether it is coffins. Regrettably, we've got to be able to become more self-sufficient in the production of these commodities, because when you have a pandemic, everybody in the world is looking for these commodities. Next slide, please. So finally, on the recovery and reset, clearly what we need to do is we need to learn the lessons so that we can recover rather quickly and reset the agenda so that we build back better, as people suggest. So, but the COVID pandemic has illustrated, I think globally, that the health systems throughout the world, together with social and economic systems, are rather fragile. And I think what was well captured during the COVID period is that the impact, both the health and the social and economic impacts, were significantly greater on women than in men for a number of reasons. And while not all countries were affected, there were significantly differential rates of infection and mortality. And I think one of the pleasing things about South Africa is that we've been able to both trial the candidate vaccines rapidly, and that stood us in good stead to know which vaccines work with the 501YV2 virus variant, as well as what works with respect to the various medicines. And the fact that we discovered these variants in South Africa also shows the robustness of our genomics and our surveillance using genomics. And I think we've been applauded the world over for that. But we have to, and this is not just South Africa, we need to build resilient health and social systems. And it is not only to deal with pandemics, but it's just to cope with the changes and the burden of disease. There are many lessons from these two waves, and we must use them to prepare in a more agile way to future waves. Equally importantly, we need to focus on recovery, given the significant impact of COVID-19 on the inadequate access that children and adults had during the COVID peaks. We need to strengthen our immunization program, diagnosis and treatment of TB, HIV, hypertension and diabetes, and cancers, to name a few. And we need to reset the agenda and build back better. I think there are significant lessons throughout the world for that. So we need to accelerate the recovery. We need to focus on a significantly more agile management of decision-making. In a pandemic, you have to have safeguards against corruption and inefficiencies and wastage, but you've got to give greater autonomy to frontline workers and their managers. You cannot manage a pandemic in the usual way that you manage services. So we've got to rethink the way we manage during a pandemic. The importance of psychosocial support to frontline workers and mental health of the population was significantly felt, and I think it's a lesson for us in terms of the so-called softer things in life. We have been able to develop and deploy digital technology rapidly, and I think there are lessons to be learned. We need to increasingly involve patients and communities and co-create health and wellness. And certainly we think it's vital for the recovery and the reset phase. There are a large number of technical partners that can be mobilized, but we have to recognize that between waves, there's both weariness and complacency. And we've got to figure out how to address this as we exit the wave 2 and we quite potentially enter wave 3 around May this year. Next slide, please. So for the health and welfare systems, resetting means investing in the public sector and the workers in the public sector of all types, so that they can provide the quality of care at an affordable cost and reduce the cost of inputs like diagnostics, vaccines, and medicines. There are some things we're still paying too much for. We've got to learn how to reduce the input costs. It also means changing the way health and social sectors provide these services. And for health, it certainly means strengthening primary care, improving self-care and home-based care, increased ambulatory care, and decreasing reliance on specialists and hospital care. And it means greater reliance on technology for surveillance, self-monitoring of vital signs, and real-time data for planning and interventions. I think those are big lessons we've learned from the COVID response. Next slide, please.
Dr.
So what are the take-home messages?
Oh, sorry, you're wrapping.
This is my last slide. Yes, last slide. So we need an all of government, all of society response to COVID. I think that's fairly clear. We need to continue to use non-pharmaceutical interventions as a key, even as we need to accelerate vaccinations. Many lessons were learned, and we need to prepare for the third wave and subsequent wave. And it's clear that planning and recovery and the transformation of the social and economic system is fairly critical, and it can't be business as usual, as they say, as we move ahead through the recovery and the resetting phase, because we will definitely have subsequent pandemics, and we need to prepare now for them. So thank you very much. Let me acknowledge in the last slide all my colleagues that have put this slide together, including the organizations that have been helping the Department of Health and government more broadly on the response to the COVID pandemic. Thank you very much.